So good morning. We'll start with androgens. So most of you are aware of the abuse part of this androgens, maybe noradrenaline injections, testosterone injections, usually by the bodybuilders and these are also found they're using the in vitro fertilization techniques where the spermatogenesis is not good. Okay, in androgens they are abused and used. Okay, so today we will learn what are the different androgens available for us and what are the anti-androgens which can be used for therapeutic purpose. Both androgens and anti-androgens find their use for therapeutic purpose. So first thing, where our androgens are secreted, how they are secreted, all these things we need to know. We have already completed the anti-pituitary hormones. I believe that you have some idea what is GnRH, what is FSH, what is LH, how they are released under the influence of GnRH from the pituitary. Okay, from the anterior pituitary we got this FSH, LH. Okay, and thereby this FSH and LH they acted on the respective organs to produce their secretions. So this testosterone are the main androgens which will be produced from our testicular organs. So GnRH, gonadotropin releasing hormone, it is released from which controls pituitary gland? Hypothalamus. Okay. So from the hypothalamus we got this gonadotropin release hormone whereby they act on the pituitary and there is release of this LH and FSH. Okay, LH is luteinizing hormone or else it is called as interstitial cell stimulating hormone. FSH, follicle stimulating hormone, it has inhibin and activin. Okay. So this is the feedback mechanism associated with this FSH. Inhibin, if it is secreted, it goes. Inhibin has both long root feedback mechanism and also short root feedback mechanism where it goes and inhibits both pituitary gland and the hypothalamus. So FSH in males, it helps in spermatogenesis and growth of this Sertoli cells. Okay, so LH in males, it can produce the androgens and testosterones in the Leydig cells. Though Sertoli cells play an important role, it is the Leydig cells which are involved in this testosterone production. So Sertoli cells, these can produce this gonadal peptides, inhibin B and activin. Okay, and this FSH, it can cause germ cell proliferation and maturation. So androgens, we have this naturally occurring ones, that is the testosterone and dihydroepiandrosterone and the androstenedione. These are the principal androgenic hormones from the Leydig cells. Do you remember what is long loop feedback mechanism, short loop feedback mechanism? So these are the two active components: testosterone, 5-alpha dihydrotestosterone, and androstenedione in the lesser quantity. Okay. So here you can see this diagram is a expression from the anterior pituitary hormones class. Okay, hypothalamus, it regulates the synthesis and secretion. Here you can see here hypothalamo-pituitary gonadal axis is there where it can be controlled by feedback mechanism. Hypothalamus under GnRH influence, this can release this FSH and LH. Okay, and in the testes, under the influence of this LH, we have this testosterone. It is the primary molecule for synthesis here is the cholesterol. Okay, from this cholesterol, under the influence of the enzymes, desmolase, okay, under the influence of this enzyme desmolase, it is converted to pregnenolone, okay, and this pregnenolone is converted to testosterone by 2 pathways. There are some minor metabolites, it may be of lesser importance. Okay, so just remember, from pregnenolone it undergoes 2 pathways where the final end product is the synthesis of this testosterone. So from testosterone we get this intermediate product, that is androstenedione and 5-alpha dihydrotestosterone. This 5-alpha dihydrotestosterone has more affinity for the testosterone receptors than the testosterone receptor. Then further it is metabolized. So androgenic steroids, where they are helpful. So once they bind to the receptors, the primary aim of this testosterone is synthesis of the sperms or the spermatogenesis. But in the early phase, okay, when growth is taking place, it helps in growth and development of the male sex organs, and it is important for the male sex drive and performance. Development of secondary sexual characters, that is, other than the sexual organs, will be the secondary sexual characters which are come about the puberty, will be growth of hairs, masculine male type baldness of the head, all these things. Okay, that's why we have found that like if the person is more bald, we go for the anti-androgens, where the male type baldness can be decreased. So anabolic activity, it helps in development of the muscle mass, and it reverses the tissue depletion process. Here we can see from the binding side, okay, here from the here we need to remember this testosterone is plasma protein bond, about 40% is plasma protein bond, okay. So this binding globulin is there, from that it is released, okay, that is testosterone under the influence of 5-alpha reductase converted to 5-alpha dihydrotestosterone, which is more active metabolite, and it has this cytosolic and nuclear receptors. And what are the different areas? You know, it will be the sexual organs, spermatogenesis, growth, anabolic effect, all these things are taking place. It is in the transcription of the specific protein. It is specifically something like a mRNA mediated process. So dihydrotestosterone is 10 times more potent and mediates the effect of the testosterone on skin and other sexual organs like seminal vesicle, prostate and epididymis. So what are the physiological growth? Okay, increase spermatogenesis, increase erythropoiesis. Okay, this increase in erythropoiesis is used. This character can be used for the anemic patients, but nowadays we have the better drugs such as erythropoietin and iron supplements. Like if the patient is chronically anemic and they are less responding to the classical group of drugs, we can always try this group of drugs. So anabolic and growth promoting effect, bones, skeletal muscles, all these things are there. Most commonly used by the weightlifters, bodybuilders, all the people. Anyone tried these injections? Noradrenaline? No one? No bodybuilders? Yeah. Any females? No. Okay, so this is most commonly abused, costliest injections. Suppose we have an industry, small pharmaceutical industry, which can synthesize these injections. Small 2 ml injection will cost you in thousands. Starting cost itself is around 500 rupees. Okay, so testosterone metabolism, it is hepatically metabolized to 17 ketosteroids, androsterone and etiopolanolone. These are the byproducts. Clinical uses, if we find that there is no conception taking place, the couple are not able to beget the children, we can go for the hormonal assays like estrogen assay, progesterone assays and the testosterone assays. If we find that the sperms are not maturing properly, if it is less than 120 million per 5 ml, all these things are the signs of testosterone deficiency, where we can go for this. Hypogonadism, impotence, aging, infertility, in all these conditions we can use this testosterone preparations. Anemia, I told we have the better products now. Leukemia, lymphoma, endometriosis, in all these areas they are tried. So testosterone preparations for androgen replacement, we have direct testosterone synthetically prepared for intramuscular and subcutaneous injection. Testosterone propionate, cypionate, methyl testosterone, O stands for oral, S sublingual, and this depot. Usually this testosterone preparations are not orally active, but when they are esterified and their activity is increased, they act for more than 15 days, 1 month, like that. Okay, so their esterification enhances their activity and makes them orally available. They can be used for breast cancers, testosterone, progesterone derivative, and aromatase inhibitor. See, we saw that in the previous step there was conversion to androstenedione and 5-dihydrotestosterone. From there further we have the enzyme aromatase, which converts them to estrogen. So it is always the males who dominate. First, testosterone is necessary for production of this estrogen. Okay, so used for anabolism in case of osteoporosis. Osteoporosis may be senile or post-menopausal. The synthetic preparations, they have their role in two forms, may be androgenic effect, may be anabolic effect. Okay, they differ in their ratios. Here you can see the drugs which are used for anabolic effect, they have lesser of this androgenic effect and more of this anabolic effect, 1:2 or 1:3. So such drugs we can use for the anabolic effect. They are stanozolol, oxandrolone, norandrolone, nandrolone, methadone. So testosterone, just now we discussed, they can be used in breast cancer. Okay. So it is for palliative therapy. It is irreversible inhibitor of the enzyme steroid aromatase that is responsible for synthesis of estrone from androstenedione. That was the intermediate product before synthesis of this testosterone. Okay, from androstenedione to estrogen, that step is blocked by blocking this enzyme aromatase. So it undergoes hepatic metabolism, commonly used for breast cancers, and hirsutism can be there. So it is contraindicated in male breast cancer. So what may be the side effects of this group of drugs, androgens? What will be the side effects? One is that you saw, that is, it is contraindicated in male breast cancers. What else? Hirsutism, acne, menstrual disorders. If it is used in children, it can lead to precocious puberty, hirsutism, okay, salt and water retention, enlargement of the prostate, and it can also lead to cancerous conditions. There are so many group of drugs here. You can see how they can act as anti-androgens. We will be discussing it in the later part. Okay. So estrogens, we have this diethylstilbestrol, mestranol, progestin, cyproterone acetate, GnRH superagonist, that is euprolide, antagonist, ganirelix. These both agonist and antagonist, you need to remember, GnRH agonist and antagonist both find their use in the cancerous conditions. One may be helping in they are primarily targeting the feedback mechanisms. Okay, by blocking their feedback mechanisms, they decrease the cancerous conditions. Glutamide, we have like bicalutamide, nilutamide, 5-alpha reductase inhibitors. Where do we use them? BPH, finasteride, okay, the ketoconazole, spironolactone, and gossypol. What is this gossypol? It's a male contraceptive. So here you can see one. Okay, first thing which is missing here is the GnRH and the influence of this hypothalamus, which is acting on that. So the GnRH receptor agonist and antagonist, that is relix and relins, which are acting on this and space. Okay, they can also block this secretion of the testosterone. Second is by the drugs which decrease the testosterone synthesis. Okay, here they can act from the Leydig cells. They can block their production by inhibiting the primary enzyme which is acting on this cholesterol. Okay, that is the rate limiting step, that is desmolase enzyme. Okay, so then we have the conversion of testosterone to dihydrotestosterone inhibition, that is by this 5-alpha reductase inhibitors which block the conversion of testosterone to dihydrotestosterone. From there we have this receptor antagonists at the phase 4, okay, where they are competitively inhibiting the binding there, okay, androgen receptor antagonists. Here you can see the ketoconazole and this spironolactone, they are inhibiting the release of this testosterone. 5-alpha reductase inhibitors, that is finasteride. Again, here receptor complex that is prevented by this cyproterone, spironolactone, and also flutamide. Spironolactone, where it is used? Potassium sparing diuretic, but it is also, which group it belongs? Potassium sparing diuretics are 3: aldosterone antagonist. Okay, so and here this further downstream procedures will be blocked. So we have the synthetic compounds such as danazole, finasteride, glutamide, bacalutamide. Okay, this both danazole finds its use in endometriosis. What is endometriosis? More common in pregnant women or non-pregnant women? Non-pregnant women. Okay, that is more estrogenic action. So, what is this endometriosis? Presence of endometrial tissue in the in and around female genital tract where the endometrium should not be present. Okay, there will be what? What can happen there? It is something like glue which binds everything. The movement of the fallopian tube is blocked. Okay, this tissue something like a adhesive glue which binds everything. There will not be movement of the ovum. All these things are taking place. The layers of the uterus can bind one to one another. Okay, all these things will be there in endometriosis. Finasteride, I told you male type of baldness we can use this anti-androgen drug, that is finasteride. Bacalutamide and flutamide we are using it in prostatic cancers. Okay, so anti-androgens find their use in carcinoma of prostate, benign hyperplasia of the prostate, severe acne, hirsutism. We can use this spironolactone, protein acetate. Okay, Have you heard of this Saheli? Saheli? Yes. So, do you remember OCP containing this cyproterone acetate? Is it used? You need to remember. Okay. Anti-fertility agents. We have this male contraceptive, that is Gossypol, and for baldness we have this topical anti-androgen, that is Cytocol and finasteride. Anti-androgenic side effects may be in the form of impotence, decreased libido, decreased spermatogenesis and decreased ejaculation. So flutamide, it is used for this metastatic carcinoma of the prostate. Okay, it's a non-steroidal anti-androgen. It inhibits the cellular uptake of this androgen steroids and inhibits the nuclear binding of this androgen to this receptors. It is hepatic under hepatic metabolism and highly plasma protein bound drug. Usually this testosterone is about 40% plasma protein bound, but the synthetic one, this will help it in prolonged action. It can be used with the LHRH agonist or this GnRH agonist. Examples: Gosserelin, Buserelin, all these things are there. RELINs are this agonist. Demerits are photosynthesis, photosensitivity and urinary color changes. Nilutamide, again it is for metastatic carcinoma of the prostate. Okay, so same as the flutamide. Okay, action is it inhibits the cellular uptake of this testosterone and inhibits the nuclear binding of the receptors. Metabolism primarily by this hepatic metabolism, and it produces major active components also. Inhibits variety of CYP enzymes, that means it can act as an enzyme inhibitor. The drugs which are used along with these drugs, their bioavailability may be increased. So advanced prostate cancer, we also have this bicalutamide, again in the same way. I am just giving this because they themselves can be given for short answers, maybe 3-mark question. Okay, bicalutamide, nilutamide, all these things can be given. You need to put it in the same way, mechanism of action, where it is used. So this bicalutamide, it has stereospecific metabolism. RNA tumor of the drug is more predominant drug, which is for our pharmacology purpose. So it can be used in combination, or should be used in combination with this GnRH agonist, okay, valence, for the better use. So this is just summarization. Okay, replacement in hypogonadism, female disorders, dysfunctional uterine bleeding, anemia, infirmity, anabolic steroids, male contraception, osteoporosis, all these are there. Contraindication, it should not be used in pregnant women, okay, infants and young children. Male breast cancers, we cannot use this, okay, and also cancer of the prostate, we cannot use the agonistic group of drug. And after prolonged use, they have found that as they are hepatically metabolized, there can be hepatocellular carcinomas. And now, thus for anemia purpose, we have this better drug, that is erythropoietin and the iron preparations. For osteoporosis, now we have bisphosphonates. Okay, have you heard of this bisphosphonates? What are those? Yes? What are bisphosphonates? Examples? Alendronate. Okay.